Well, I think it's been an exciting day today at ASCO GU. We virtually realized that EV-Pembro is one size fits all. So for localized disease and for advanced disease, this is really the holy grail. Results are overwhelming and changes the way we practice both in metastatic disease and in local disease. And we are in an era that EV-Pembro will be widely implemented for all comers. So it's really, really exciting times. Absolutely. So the concept is that EV-Pembro is a very powerful combination, but not all patients respond to this therapy. About 10% progress directly on this therapy, and another 20% has stable disease. And those are responding eventually, more than half of them will progress. So the question is, can we target the progression, the resistance in the tumor? And with that, we have different strategies. One of the strategies is to enhance the immune checkpoint inhibitors. So one of the targets is LAG3. LAG3 is co-expressed with PD-L1 and is part of the Treg exhaustion in the tumor that can lead to the resistance of the tumor. Another target is the TIGIT. The TIGIT is also expressed in the tumor cells and APC, and is also related to the tumor exhaustion, to the Tregs activity. So targeting this co-expression makes sense, and in the preliminary study, it was very promising strategy to enhance response without a price of heavy toxicity. Like when we add ipilimumab, the anti-CTLA-4, we add significant toxicity. But when we target the LAG3 and the TIGIT, the potential was to increase response with a modest price. So unfortunately, what we see in this sub-study, the Keymaker 04B, is that adding this co-formulation separately to EV and Pembro resulted in higher toxicity, more treatment discontinuation, but there's no signal of significant efficacy. And therefore, this is a negative trial. And still what we realize is that the Holy Grail is still EV-Pembro, and this triplet strategy is a failed one. So I think it's the main question is what to do next. We don't have a clear answer. There are multiple options, and there's no one path. Maybe I'll start with the FGFR mutations. They will shift to erdafitinib therapy. There is a publication from Memorial for patients progressing on EV-Pembro receiving platinum-based therapy, and we see there about 30 to 40% response for about 4 to 5 months. So this is one option. Another option is to test for the HER2 expression, and that's going to be one of the main targeted. And we have that FDA-approved regimen, trastuzumab deruxtecan, which is approved for HER2 plus 3 overexpressed patient. This is a different target and a different payload that make a lot of sense. And of course, a multiple clinical trial trying to assess if we should use a different ADC with a different target or a different payload to get the response again for those resistant cells. So multiple options. I think one of the best things for the patient is to be enrolled to a clinical trial.